Hi viewers, today we'll see care of patient with epidural anesthesia. I am Dr. Kalaisal Xavier, Professor, Triple M College of Nursing. At the end of the class, the students will be able to mention the meaning of epidural anesthesia, specify the uses of epidural anesthesia, explain the indications of epidural anesthesia, specify the steps of procedure, enumerate the nursing role of patients with epidural anesthesia, explain the risk of epidural anesthesia, and list down the complication of epidural anesthesia. As an introduction, before to know the epidural anesthesia, we should know what is the difference between epidural and spinal space, where it will be inserted, what is the action, etc. The spinal canal enclosed with the structure is also known as the epidural space. Apart from the central portion, which is occupied by the dural sac, and it contains the duro matter, contains the arachnoid matter. Where the epidural space contains fat, the dural sac, spinal nerves, blood vessels, and connective tissue. An epidural injection may be administered at any point of the spine, but most commonly between the duro mater and the ligamentum flavum is the epidural space. This is the general anesthesia and regional anesthesia structure, where the general anesthesia the patient fully unconscious. The regional anesthesia, there are different types in that epidural, spinal subarachnoid, peripheral nerve block. The epidural can actually be made up of two parts, including epidural anesthesia, which is a lack of sensation, and epidural anesthesia, which is a lack of pain. It's injected into the epidural space located in the spinal cord. First, the local anesthetic is used to ensure minimal discomfort. The anesthesia and analgesia. Analgesia is the absence of nociceptive stimuli with the preservation of motor and touch sensation. Anesthesia is the absence of all sensation including pain, touch, temperature and pressure. Okay, now we will see what is epidural anesthesia. The epidural provides anesthesia that creates a bond of numbness without sensation. That particular area will be having patient's numbness from the belly bottom to upper legs. It allows the patient to be awake and alert throughout labor as well as to feel pressure. The ability to feel second stage labor pressure enables patient to push when it's time to give birth to the baby. Uses of the general epidural anesthesia. There are often used during labor and delivery and surgery in the pelvis and legs. The epidural and spinal anesthesia are often used when the procedure or labor is too painful without any pain medicine. The procedure is in the belly, legs or feet. What is the difference between spinal anesthesia and epidural anesthesia? Back to epidural and spinals. The main difference is the placement. With an epidural, anesthesia is injected into the epidural space. With a spinal, the anesthesia is injected into the dural sac that contains cerebrospinal fluid. The direct access means that a spinal gives immediate relief. What are the indications for epidural anesthesia? Mainly the epidural anesthesia, those the patient is on ICU with blunt trauma, with or without rib fractures, thoracic trauma, abdominal injuries, the orthopedic and vascular surgeries, as well as non-surgical problems such as intractable angina pectoris and acute pancreatitis. hepatitis. Contraindications: the patient use of the neuroaxial, that is epidural or subarachnoid technique include patient refusal, active maternal hemorrhage, septicemia, infection at or near the site of the needle insertion, and clinical signs of coagulopathy. This is the steps of epidural anesthesia. As with the sterile technique, once the needle is in the proper position, the epidural catheter will be threaded through the needle into the epidural. The space the needle is then removed, only the thin catheter tube remains. What are the role and responsibility of the client with epidural anesthesia? What is the first nursing care? Check the level of the pain score. After the patient had surgery and came to the epidural anesthesia, every 2 to 4 hours the pain score to be checked, whether the patient is no pain, mild pain, moderate pain, and severe pain. The second, supposed to check pulmonary system every second to 4 hours. Adequate ventilation, respiratory rate more than 10 breaths per minute with adequate depth of respiration, skin and mucous membranes color normal, arterial blood gases within normal range, patient able to cough or deep breath with a little difficulty. The nursing care of third, vital signs. As nurse should be checked heart rate, blood pressure, respiratory rate, oxygen saturation should be monitored hourly for the duration of the analgesia, 8 hours in receiving fentanyl and 24 hours receiving morphine. The fourth, safe practice for epidural anesthesia administration as ordered. This is very important. While the patient is on epidural, medicine supposed to be given through epidural. It should not be given by mistake. Check the physician order. Perform double checks at the bedside for the epidural analgesia. Prepare the medication administration in sterile technique. Clean the epidural site of injection port with alcohol swab. Store epidural and IV solutions in separate location. Administer the injection slowly in sterile technique. Clearly label solutions with the label the state for epidural use only in large font. When the patient is on, it is in the back here, actually in the shoulder, right upper side, it should be fixed. Use yellow lined tubing without injection ports for epidural administration to make it look different from IV tubings. Monitor patient's outcomes and for adverse reaction to epidural anesthesia. There, one of the hospital when I was working, I have got a chance to see the patient with epidural anesthesia. There they have not fixed with that in that shoulder. They have fixed in the pillow, the right side of the pillow. They have fixed. The fifth one is the neurological status. Hourly, we have to check the neurological status, level of the consciousness, sedation scales in assessing for signs of respiratory depression. If it is a 0, no sedation, patient is awake and alert. The mild sedation means the score is 1, occasionally drowsy, easy to arouse the patient. If the score is a 2, moderate sedation, frequently drowsy, easy to arouse. Score is a 3 means severe sedation, somnolent, difficult to arouse the patients. If it is a S means the patient is asleep, normal sleep, easy to arouse. Then sixth, we have to check paresthesis. Paresthesis is, should be checked hourly. Inform the patient the paresthesis only lasts a short time. If numbness or tingling persists, contact the physician. 0 means no movements. 1 moves legs on bed. 2 lifts legs and falls back. 3 lifts legs and holds. 4 normal movement. Then the seventh one, assessing the sensory block. Explain the procedure to the patient and family. Wrap an ice cube in tissue or paper towel, leaving on area exposed. Place the ice on an area well away from the dermatomus and ask how cold does this feel. Apply the ice to an area expected to be numb and ask if it feels the same cold as your face or different. Apply the ice above and below this area until you determine the upper and lower dermatomus blocked. Assess one side then the other to see if the block is unilateral or parallel. Then continuation of that, record the level from which patients feels the cold sensations. T10 means at midpoint of the umbilicus level, that is an inadequate level of numbness. T8 from umbilical to fundal region, level B, that is a safe level. T8 is from umbilical to fundal region is a safe level. T4 is from fundal region to the above the nipple, level C, that is a caution. Above nipple line, level D, it is a danger. Then eighth one is a assessing motor block. Ask the patient to do flexion, that is a promage 0, none, full flexion of the knees and feet. Promage 1, partial block, just able to move knees. Promage 2, almost complete, able to move feet only. Promage 3, complete block, unable to move feet or knee. Ninth one, epidural catheter site. Fourth hourly, the epidural catheter site to be assessed. Catheter site, dressing, complication, etc. Pain on injection, post-dural headache, epidural abscess, hematoma, catheter occlusion, migration, sharing. Protect catheter by ensuring it is kept free from catching on bedside, etc. Take care of when moving around bed or out onto parent's knee or into a chair. Ensure catheter is connected to filter and secured with tegaderm. Then 10th one, loss of epidural catheter or leakage. It should be checked 3 hourly. Check epidural site for any leakage. Contact on call anesthetist if excessive leakage around site and pain. Protect catheter by ensuring it is kept free from catching on bedside, etc. Take care when moving the patients around bed or out onto parent's knee or into the chair. Ensure catheter is connected to filter and secured with the deck. The 11th one is a narcotic related side effects. It should be checked 4th hourly. The patient should have hypertension due to allergic reaction ranging from mild urticaria to cardiovascular collapse. Then the patient feel to have nausea, vomiting, occurs 4 to 6 hours after administration. Then pruritus. Usually patient should have 48 to 72 hours in patients receiving continuous morphine. Urinary retention first 24 to 48 hours and then it will be resolved spontaneously. The 12th to be checked, removal of the epidural catheter. After 3 days, it shouldn't have in that site. It should be removed. Wash hands and put on the protective apron. Open dressing pack. Remove dressing from patients. Anchoring the epidural in order to ensure it is not removed inadvertently. Apply sterile gloves. Apply traction to catheter. If resistance is felt, stop the procedure. Ensure patient safely and seek assistance. Check the catheter tip to ensure integrity indicated in most products by the complete blue tip. We have to check the tip of the catheter. Clean the skin and with the antibacterial solution allow that to dry. Apply on occlusive dressing. Reposition patient to ensure they are comfortable. Dispose of waste, wash hands and document the procedure. Ensure the patient receives the correct observation and to alert for any motor or sensory disturbances. The access site should be checked frequently after catheter removal for redness, pain or swelling. After removal, sensory or motor disturbances must be observed and reported immediately via the appropriate mechanisms. The 13th one, the potential for infection related to indwelling epidural catheter. Each day it should be checked. Assess catheter insertion site for pain, tenderness or other signs of infection. Assess for fever, knuckle rigidity or changes in the loss of consciousness. Notify precision if present. Notify the physician if the catheter tip is not intact upon removal. What are the risks of the epidural anesthesia? There are so many risks. Epidural anesthesia is very safe but not risk free. Risks include hypertension or low blood pressure 10 to 20%, infection less than 0.01%, bleeding less than 1%, puncture in spinal cord with tap or dural puncture 1%, headache less than 1%, allergic reaction less than 1%, failed block and intravascular injection 1%. Other complications very rare, convulsions, severe breathing difficulties, and it can be happen death. Because deciding to have an epidural should discuss the procedure with the anesthetist. They can provide further information, advice on the risk of developing complications. Conclusions: epidural anesthesia with the continuous infusion of the local anesthetic opioid mixture is currently the most effective method of providing pain relief for major thoracic surgery, according to 2000 Royal College of Anesthetists.